I call this meeting to order at 6 o'clock p.m. Madam Clerk, can we get a roll call, please?
Director Burnworth.
Here.
Director Goodself.
Here.
Director McGart. Director Proctor.
Here.
Director Berker.
Here.
Director Valdez.
Here.
Director Garcia.
Here.
Thank you. Would everybody please stand for the pledge of allegiance? Ready, begin. I
pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
At this time, the board will hear comments on any agenda item. If any person wishes to be heard, he or she shall stand, address the board, identify itself, and state the subject for comment. Time limit for each speaker is 3 minutes. If the speaker wishes to speak on multiple items, the speaker will get 4 minutes across all items. A total of 15 minutes shall be allocated for each item for members of the public. The board may find it necessary to limit the total allowable for all public comments on items not appearing on the agenda at any one meeting to 1 hour.
Thank you. Honorable Board, here to address you, I was asked by Supervisor Ryan Kelly to read a letter which he has written, and he will be probably formally introducing it, but he asked me to read it tonight to you because he could not be here. He has another meeting in Ireland at the present time, and so he had asked me to fill in his stead, so I will read the letter. He states that your board is now entrusted with protecting a legacy of our community and the employees of the facility. This is not how we hope a consolidated healthcare district would be implemented nor conducted. Regardless, you now have the responsibility to guide these community resources for the betterment of Imperial County. Trust must be earned and not given. Therefore, I request the IVHD board make the following commitments by resolution. Number 1, not close medical service departments at Pioneers Memorial Hospital for a period of 5 years. 2, IVHD will follow the conduct of an open hiring process for all management positions. 3, IVHD will not sell or leverage any property or asset of the former Pioneers Memorial Hospital District system for 5 years. 4, IVHD will conduct requests for proposals for all management agreements of the healthcare district. 5, IVHD will not hire any former state, county, city, or district elected official for 5 years. With these actions, your board can build community support and safeguard the employees of the former Pioneers Memorial Healthcare District. I join with others in praying for your success in delivering greater healthcare services. Thankfully, Ryan Kelly, Imperial County Supervisor. He asked me to read that. I share some of that sentiment as a 71-year Brawley resident. I am concerned, but I know that you will do everything in your power to make this a success. And I hope that that's what happens. And I think that's what most of the residents of Brawley are praying for. So thank you for your attention. Appreciate it.
Thank you, Mr. Hammond.
Good evening. My name is Kevin Smith. I'm a resident of Brawley, 75-year resident of Brawley.
It doesn't look like you lived here that long. Possibly lived
Well,
here
I
that
wasn't born here. I was born at the sanitarium way back when, but my younger brother was. So, I'd like to start my comments by asking you to please look at the El Centro Regional Medical Center's most recent financial report. It paints a very concerning picture. Despite some of their best efforts, they've been on a continued downward spiral for quite some time, and costs are rising. And most notably, the costs associated with UCSD and CEO compensation. Of course, UCRMC is carrying more than $220 million in liabilities, and I don't have to remind you that under AB 918, you guys must acquire all the assets and liabilities. Just to continue the point, the most alarming issue here is that UCRMC has, as of December 31st, 10 days of cash on hand. And as a metric, that is horrifying. So now IVHD continues to entertain negotiations with ECRMC for an acquisition, and we need to ask, if this deal goes through, what will it mean for our taxes and ultimately for the financial health of the only other viable hospital? Are we prepared to foot the bill for ECRMC's massive liabilities as well as any ongoing support to keep it operational, including exorbitant fees to UCSD? We taxpayers need to be very clear-eyed about what acquisition of ECRMC would mean. It could require more tax dollars out of our pockets just to keep them from collapsing. If it does collapse, or if a tax measure on the ballot fails, there's no backup plan. Anyway, in plain terms, we need to address these issues head on.
Thank you.
Thank you.
Good evening. My name is Ron Rubin. I'm a resident of Brawley. I come to you to play my old tune. I've changed a little bit. The last time I was concerned about negotiating with El Centro. Now I think right now our best move is to step back. They haven't tried. The year they've lost $7.5 million since June. And you haven't heard a doggone thing about it. You might have, because you're closer to the negotiations. But out the public, El Centro citizens have no idea that they've lost that much money. And at that rate, they'll bankrupt everybody. You know, I mean, and we'll be underwater, with the hospital that you're in charge of now. So I would recommend you don't move forward, and if you put that on hold until either there's some money coming from the state. Well, that's the only place that I can see it coming from. I was concerned about the debt. I'm still concerned about the debt, but that's needs to be paid by the taxpayer, but the taxpayer cannot fund operations. There's not enough money that you'd get approved to fund an operation that has been losing so much money. And then my second point is don't sign that joint filers agreement with San Diego. They've had 9 years to turn El Centro from a profit maker to a serious loser. Don't give them the chance to do it to our whole district and healthcare in Imperial County. Now, I also, last time I offered to have somebody talk to people, and then I realized I didn't give you any contact information. So I'll give you another chance and not think you've already made up your mind. Thank you. And I have my business card for you. Thank you. Thank you. Yes, sir.
Thank you, Mr. Thank you. Do we have any other public comments? Seeing none, we'll move on to item 5, update, discussion, and possible action regarding item A is approval of recommendations from the MEC committee. Dr. Parra.
Madam President and members of the board, I'm here representing the medical staff at the Point Memorial Hospital to give the recommendations from the recent medical executive committee regarding the various membership and clinical privileges, the policies and procedures, and other related recommendations that were approved by the MEC. A copy of this has been provided to you for your kind perusal. I'm here to highlight some of the items. Several of the providers were initially appointed, some of them reappointed, and many of them released from proctoring for various specialties. They have been presented to you. A number of policies were approved, and a copy of that is also available. The item number 7, the MEC was excited to have Mr. Chris Bornberg welcoming back, and he has been closely working with the MEC previously, and we would like to share our concerns, and we're glad to have him back in a part of the discussions. The transfer of critically ill patients continues to be a problem, partly because of overcrowding at every hospital. Previously, we had fairly easy access transferring patients to scripts, but that's sometimes it's a bump, partly because of the New Year and Christmas holidays. They're overcrowding everywhere. We assume that's part of the problem. So we are hoping that we will continue to improve upon what is available here that is on par with San Diego, except for some exceptional patients. So that's the goal of all our efforts from the medical staff and the administration. We seek your kind guidance and help in this regard. We have been closely following the requirements of the DNB, and one of them is respiratory massivity. COVID-19 reminded us it's so important, but now it is important that we have a documentation that every provider has some.
Copy, I'll just drag it to the chat
That
and
is
send it to
being
me.
pursued.
I'll send it as an email.
And several clinical departments presented
I
their
apologize for the delay.
recommendations in the meeting and bylaws. So I humbly present to your kind consideration to approve each of these
Did you put our
recommendations of the MEC for medical staff
where?
membership
Where's the name go?
and clinical privileges as outlined above.
Open it.
And I'm here standby to accept any comments or questions. Thank you.
Any comments or questions from the board?
I have a comment on the new policy, oxygen administration. That was a total rewrite. The other ones are just revised, but I just wanted to know on that one if it was actually circulated or.
I think it has been brought to the attention of the, particularly the nursing staff. I think Carol Burkes can expand on that. She was one of the primary authors.
So there has been a request to revise policies as much as we can to make them more concise, make it easier for staff to be able to utilize. So in the future, you will be seeing a lot of policies that it'll be a complete revise, trying to get them under 2 pages, just to make it easier, more to understand, and then also to access the information that's needed to take care of the patients. You'll also notice that the policies now are being sent to the chair of each service, and you'll see a physician name usually written on the policy if it relates, if it can impact, providers. And so those are some of the changes that have been made. We're still working in the process. Sometimes, they're not sure if it needs to go to the provider for collaboration or not. But when that happens, we will usually send it back for collaboration with the provider. And then just, again, you're going to see a lot of policies, the clinical ones mostly complete revision. It's just easier to say that versus list everything that was changed.
And then I had another question. I don't know, maybe Carly could answer this one, but on the medical imaging for the MRI tech, we don't have one for the weekends.
So we just hired a per diem that is going to be onboarding next week. So they'll go through training. So I did send an email out to the ER, to Dr. Nelson and some of them hospitals here today to let them know that we had hired somebody. So we'll be expanding to 2 weekends a month. So we'll be expanding outpatient as well, because we don't know the volume of the ER at all times. And then from there, we'll evaluate if we're going to hire a
And do we have like a count on how many outpatient MRIs we do?
I can do that.
The utilization of it, maybe if we could get that.
I get a monthly report.
Because there was kind of concern that it was underutilized. That's all.
Any questions from the board?
On the policy specifically, there's, maybe I'm just not seeing it, but there's nothing that indicates when the policy will be revisited or revised. Is it on an annual basis for revision or just to look over, or is there?
There's a revision date on the header, and most policies are revised every 2 years. If it's a work instruction, then it's every 3 years. If it's a standardized nursing procedure, or because of regulation, compliance issues, some of those are 1 year. Those are usually like the disaster plan, infection control, those kinds of policies require for 1 year revision. But it's listed on the right side on the head, your right hand.
Okay, yeah, I see where the revision took place, but generally on a policy, you'll see visited next within 1 year.
Oh, you're.
Subject for revision within 1 year, 2 years.
So 2 years, most policies, 1 year for nursing standardized procedures, anything that's regulatory for compliance issues, and then work instructions every 3 years.
Okay, thank you.
And usually when it's annual, you'll see on the top where it says annual review. And then you'll see that.
Do you have any other questions from the board? Now, entertain a motion. Do you have a motion?
I move to approve the recommendations from Medical Examiner Committee.
Do I have a second?
Also,
I have a motion by Proctor and a second by Medard Jr. All in favor, say aye.
Aye.
Any opposed? Any abstention? Motion carries. And we'll move on to item B. Authorized annual service agreement for automated urinalysis machine with Beckman Coulter Incorporated.
So this is a annual service agreement for our laboratory. We purchased this in 2023. It did come with some maintenance, a 1 year maintenance at that time, so that has now expired. So we are bringing this to you guys tonight for the preventative maintenance. It's $16,697 annually, and we do about 12 to 14,000 annually are performed. So it is needed, highly utilized.
Do we have any questions? If none, I'll entertain a motion.
I move to approve item B.
Do you have a second?
I have a comment on the service agreement, and not only this one, but most of them are still labeled Pioneers Memorial Healthcare District. We're going to change that to Bear Valley Healthcare District.
Yes. We will. We can, because the contracting obligations transferred to IVHD, we can continue to use the Pioneers Memorial Healthcare District name for the purposes of ensuring the continuation of business, because all of the obligations were transferred to IVHD through AB 918. But wherever possible, and this is something Chris and I have chatted about, wherever possible, we do intend to change the names on the contracts to the legal entity of IVHD. Sometimes we might have to say IVHD as successor in interest to Pioneers Memorial Healthcare District where appropriate. So we'll make sure and check for that as we go.
Thank you.
Also, I noticed on them as well, the signatory page needs to be updated. Or no, it's not on this one. But on a lot of them, the signatory page needs to be updated. So I think I had a motion by Berger and a second by Medard Jr. All in favor, say aye.
Aye.
Any opposed? Any abstentions? Motion carries. Thank you. I'll move on to item C. Authorize replacement of service compressor and maintenance of starter coolant for chiller number 1.
So we have 3 chillers that do the bulk of the work in the summertime to the hospital. One of them is being replaced at this time, and last year to get it to work for us while we were getting it replaced, we did the same setup where we replaced the compressor and did some maintenance on the starter coolant, and it worked really well. It is a pretty hefty amount, but as you can imagine, in the summertime, we want to have this happen before that, so we can make sure that that chiller is up and running, and so we can continue to provide services. So that's why we decided to go that route. We want to be a little bit proactive with this one and make sure that we don't have any issues come summer.
And I know that the chillers were I remember seeing chillers budgeted in the distress hospital.
Yeah, that's the one that's being
coming in?
replaced right now, so we're working on that. This one, like the other ones, obviously because of how that process works, HCI's involved and there's a little bit more time it takes, which is why we're still not completely finished. But this one we can do without that because we're just replacing components and parts. And so this will take care of that chiller, and hopefully it will work just like it did for the other chiller.
And also too, it's very important because it controls the humidity in the hospital, and that's very important.
Chris, do we put that out to bid, or is it because we're on an existing contract that we're doing the parts and stuff?
On this one, I couldn't tell you for certain. Initially, when we did it, for the last one we did put it out, there was only one that would do it because they're pretty old. And so we actually found somebody who would do, essentially these are rebuilds. That's what's taking place. And so my assumption is that we went with the same company because they were the only ones that would do it before.
Any other questions?
For the scope of work, it says, sending, item 9, sending compressor to be rebuilt by York. And then 10, it says install rebuild compressor.
Yes.
And then on 17, it says ship all compressor to factory.
Yeah.
What compressor is that?
It's for the one that's being replaced.
But it's going to be rebuilt, isn't it?
Correct. So no, I'm talking about the chiller that's going to be replaced. My understanding, how Oscar explained it to me, is we switched the chillers that was to be replaced because of what we did last year work, and so the chiller that is going, or that's being replaced, they're going to take that compressor and have it rebuilt so that we can have it on site, so that we have a backup in case one of them go down. So they're taking the one from the one that's being replaced to do the rebuild.
Okay.
As part of that.
Has there been any further consideration as to other components that may be able to be salvaged from those older units that can be kept on hand?
I'll double check with them. That was the only one that they expressed to me. But yeah, we try to make do with everything that we can.
Yeah.
So, but I can follow up and let you guys know.
Do you have any other questions? No.
Just one more question. How many chillers are on site?
3. There's 3 big main chillers.
So is there a consideration being given to the replacement of this one on next year's CapEx budget, or the replacement overall? I mean, is there a succession plan to make sure that we're not just continuing to Band-Aid the problem?
Each chiller costs $900,000 per place, so that's why right now we're only replacing one. What we've been told, if we fix it like this and it works, it will work for many years down the road, so we won't have to replace it for like 5 more years. So it's kind of essentially giving us a brand new machine instead of paying $900,000 to fix it, or buy a new one, sorry.
Right. And some of this will potentially be things that are addressed as we do the seismic updates.
Do you have a motion?
So move to approve as presented.
Second. I have a motion by Medard Jr., and a second by Berger. All in favor, say aye.
Aye.
Any opposed? Any abstentions? Motion carries. And we'll move on to item D, authorize renewal of maintenance agreement with Canon Medical Systems USA Incorporated.
This is the same contract that was approved last week.
That's
So,
what I thought.
yeah, so
That's what I thought.
it was approved, just awaiting signature. I did confirm, one of the questions last week was how old is the current? We did purchase it in 2010. Correct.
So then we'll move on to item E, authorize annual membership dues with Hospital Association of San Diego and Imperial County and California Hospital Association.
So these are the dues that we typically would pay as a hospital, and it's based off of bed size and then other things like that to come up with that dollar amount. These are the guys that essentially do a lot of the lobbying for us for many of the healthcare issues that are out there. We currently hold, as pioneers, a spot on the board for that hospital, for the San Diego Hospital Association, which is part of the California Hospital Association. So that's what we're paying for, is essentially the lobbying and access to be able to help with that and find those things, or not find those things out, but we'll have our voices heard and take things to them that they can then take and hopefully help us with.
Is that the organization that was lobbying against IVHD when we were up at the Capitol last, a few months ago? Is that the same organization?
No.
Any other questions?
I just want to make a statement that I think $96,000 could be used elsewhere in the hospital, paying dues to a lobbyist. Sorry.
I mean, all of that goes into the things that that they do. For example, they were a big push on the proposed legislation for the MCO tax that's out there. So there's a managed care tax that those companies pay to be part of that process, and that money all goes into a pot, and it was supposed to be set up in semi-dog-eared, if you will, for healthcare, in particular to pay for those services for our Medi-Cal patients and be able to spread that to those hospitals that do that. When the budget deficit was what it was for us last year in California, instead of that money going where it was supposed to, the governor elected to take that money and use it to help cover the deficit, instead of where it was supposed to go for healthcare. And so they lobbied to ensure that the MCO money actually goes to healthcare, and actually successfully lobbied that. And so that made it so that the governor or anybody else can't go and take that money and use that. It's a big deal for a lot of us that there is quite a bit of money in there that can come back to us. Like overall, I don't know how much we see directly, and we'll see how we do that. But it is actually more. It actually more than covers this amount here. That's one example of things that they've done. So anytime that there's anything essentially healthcare related, then if we're part of that organization, we have a seat at the table essentially to be able to say, hey, this is what we feel about that. And we actually, as being on the board, that kind of helps us out even more. And that gives us that voice to be able to say that, especially for us, being on the board is a big deal because we're smaller. And so being able to say, hey, these are the things that affect us, and we want to make sure that these things are being covered as they try to do some of this legislation, that's extremely helpful to us from that perspective.
Yeah, but I actually want to counter that with it was the California Medical Association, Prop 13 for targeted rate increase for physicians, primary care and specialty was where that money's going. It's not really going to the hospital, it's going to professional services. so.
Some of that, yeah, yeah.
Just want to make sure that you're aware of that.
It's one of those things where if we don't have a seat at the table, our voice is harder to be heard. So voices are usually stronger together.
Right. That's kind of the idea behind it. But I mean, I do agree with Nola. It is a pretty steep amount for that. And that's every year, just so you guys are aware.
How many people sit on that board? How many organizations sit on that board?
For ours, I believe that there are 7 members on that board. And then there's other hospitals that are just part of it, but they're not actually on the board.
So you have kind of like pay to play kind of thing? Because
Well, no, like, well, to be a part of it, you have to pay, yeah, but not, like, to be on the board, because of our location and where we're at, we get to be on the board, so that we have proper representation. But yeah, in order, like, they'll still do things, obviously, even if we're not members of that. But as far as us going and having some of those conversations and being able to, like, they're going to listen to their members before they're going to have a conversation with us about anything. If we have issues and want to push something, or we have problems in our area with specific things and we want to get something changed, the likelihood that we're going to be heard by that organization is very small if we're not members of the organization.
Kind of adding to Enola's comment there, I guess, a little bit, I'm just curious about the effectiveness as far as, this is for state issues, right? State legislation?
State and federal.
And federal?
Yeah.
I mean, one that I'm just kind of thinking out loud, basically, if we don't contribute, we still benefit from it because it's for the greater fight, right? For the health organizations as a whole,
Right.
not for us specifically.
Correct.
And if it is for us specifically, did Pioneers try to work with them against AB 918, and how effective were they in helping them with that? So just questioning, like, how effective are they as far as bringing the fight for you if you're a paying member?
And on those individual fronts, it's very unlikely that they will do much with that, because it is something, when they look at it, it's going to be things that are more global. They can position you in front of people to help with those type of things, but it's not like they're going to necessarily put out anything from CHA that says, you know, we're in direct opposition to this that only affects one hospital or 2 hospitals.
My only concern is this is for the Hospital Association of San Diego and Imperial counties, and for Imperial counties we're at, you know, essentially.
We would be the only ones that would not be members if that was the case.
And I think, you know, I'm in agreement, like, I think this price is steep, but also, do you want an association to just lobby and hear San Diego issues, or do you want them to hear Imperial County issues as well?
I agree. I think that, you know, if you're not at the table, you're on the menu, and so yeah, there has to come a point, you know, where we revisit this issue and, you know, evaluate it. I'm going to say over this next year and see, you know, are we truly getting the bang for the buck, or is this something that we drop next year? And so I appreciate your comments.
And Chris, I'm just concerned that moving forward, if there's dues that we're paying kind of willy-nilly to associations, it's like that Better Business Bureau, you get a sticker to put on your window, but it doesn't really mean much, right?
Right.
So I wouldn't want to spend the money from the district on associations like that, just to say, oh, I'm a member, when the district and the community doesn't really get a benefit out of it.
Yeah, I agree with that, 100%, I agree with that.
I do believe in lobbyists for things that we need, obviously, because it's necessary. That's my only main concern.
Do you have any other questions, comments, and motion?
Any questions?
No?
I don't have any questions.
Do you have a motion?
I move to approve the membership dues to the Hospital Association of San Diego and Imperial County and California Hospital Association.
Do you have a second?
I'll second.
I have a motion by Proctor and a second by Menard. All in favor, say aye.
Aye.
Perfect.
Any abstentions? Motion carries 6-1. Now we'll move to item F, authorize CMAR's professional services from Oracle America Incorporated.
When we implemented Cerner, our new EMR system in April, part of a module that came with it is a contract management system, which says I can put in my Blue Shield agreement, this is the rates I should collect, so when I bill out, it will automatically tell me what I should be collecting for that. We've tried to implement it in-house and then keep up with it, because it also has Medi-Cal and Medicare, and you have to update those quarterly and some of them monthly. So we've had some difficulties keeping up with that, which means just more manual work on our side to fix any discrepancies. Cerner recommended the CMAR's vendor to go through the implementation, make sure that everything is in there right for agreements, update throughout the year while we can get our resources this next year together. And then hopefully next year we'll take it over, bring it in-house. That's what that's for.
Essentially to get all the bugs out and get
Correct.
you guys caught up from where you guys are behind.
Yep.
in the minutes.
Yes.
Do you have any questions?
I don't have any questions, but I do have something to say. Like Mr. Smith looked at the financial report from ECRMC that was presented on January 27th. Their financial report did talk about some slowdown with regard to Cerner. So I didn't know what that was about. I looked it up on the internet and just typed in Cerner slowdown because I was interested to find out why the revenue for El Centro Regional went down with respect to Cerner. So I went on the internet and I learned that Cerner was purchased by Oracle a while back, and that Oracle basically owns Cerner. And with the advent of AI and that AI revolution, there's other companies that are coming out and competing with Oracle now. So that's part of the reason why Oracle is having a slowdown. I brought this up at the last meeting about potentially down the road looking at a different system such as Epic. I know there's other systems out there, that's the only one I know, forgive me. But I think that if Oracle is going to keep going down, then maybe this is the time where we need to really start looking at having a different system, because if Oracle goes bankrupt per se, we're going to be out of luck. And I understand we have to do certain maintenance agreements and things like that, but it really concerned me. And like Mr. Smith said, from October to November, El Centro Regional went from 26.88 days cash on hand in October, and then in November, they're at 13.54 cash on hand. And if you throw Cerner in the mix, I mean, that could be something related to why their days cash on hand is going down. So I'm concerned about Cerner, is I guess is what I'm getting at. And we may need to start entertaining looking at a different system.
So it's not necessarily that Oracle brought up Cerner. So when you implement a new EMR system, during that first 2 weeks at least, they want you to cut back your surgeries. They want you to cut back all your clinic, all your scheduled visits. So your revenue does drop because they want to make sure that the implementation is correct, because it's obviously, patient satisfaction as well, because we do have issues, things go slower. So during the first 2 months, you'll see a drop in their revenue, or 2 weeks, you'll see a drop in their revenue, and you'll see a drop in our revenue if you look back to April 2024. And then also you'll see a drop in the cash collections. Sometimes Cerner cash collections can be decreased for up to 6 months. Luckily, ours started to catch back up after 2 months, but in May, we did see about a 30% decrease in our cash collections. The reason is normally you're sending out your bills constantly, every day. But for the first usually week to 2 weeks, depending on the hospital, you don't bill out because you want to scrub all of your charges, all of your billing, make sure you have clean claims before you even send them out the door, because you'll get denials if you don't. So that's what that slowdown is for every hospital that's out there.
And it's every EMR. Anytime you do a changeover, even with Epic, the same thing happens.
Thank you.
Yeah, it takes about 6 months to recover.
Would you guys say that you fully recovered from your Cerner implementation? Like Financially, I've heard that there's other issues that come with it.
Yeah, we still have issues. Like we did have a dip in cash in November, December, but then January has made up for that stuff. So there's always still issues. And like we're able to have a lot of charge capture stuff that we didn't have previously. So we still have a lot of bugs, but it is getting better and better.
So there's like the potential to collect more, but in the meantime, you gotta like power through it pretty much.
Yes, correct. Yeah.
It's a big undertaking for the team anytime they do something like that. It's huge. In fact, Karen can tell you, and she kind of alluded to it last time, but there was a lot more of traffic going into the gift shop and buying candy and chocolate during that time frame as people were stressed out. So.
You sell alcohol
Thanks for the explanation. I appreciate it.
And this is only for 1 year, from what I understand.
Yes, they tried to have it connected with our Cerner agreement, and luckily they actually did this one for 1 year. Some of the other modules, they won't allow us to do just for 1 year, they want the whole 110 months. So they did agree to 1 year.
And what staff member will be reviewing these reports then?
Well, right now we have the director of patient county, but we also have a revenue cycle director, and then there is individual inpatient counties that would do that. Obviously, things could change the next year of who takes it over, but those are the ones that are on these.
Let's let them recover from Cerner right now, and then next year they'll take over. Okay.
Is there any training associated that comes with this?
Yes, there was training with one individual, unfortunately, that had to change after, and then another individual was trained. So there will be also training, and there's going to be monthly meetings with the company, the vendor, with us, and going over their discrepancies in the system. So.
And it does happen a lot, that insurances do not pay what they're supposed to be paying, so it's definitely a good deal.
Yeah, it will show that we need to follow up with them because they didn't pay us what the contract said. So it's we'll be good. We never had that before. We just accepted what we got. We'd be able to look, but sometimes, I think we don't need to act right there and have a report that tells us.
That's awesome.
Do you have any more questions from the board?
I do, one last question. So on this document here, it's 8520, but on here it's 85320. So just want to know if that's a discrepancy.
It's probably a typo.
Okay.
Got fingers. Yeah, sorry.
So which one is it?
Oh, actually, 85, no, the 85, so what it is, it's 85,000 for the year, because the 8520 is just like a fixed price for that, the first, like say, first implementation, and then it's a monthly fee. So it's the total for the year.
Okay.
I have a quick question, it's just out of curiosity, as you mentioned, before we didn't have the system, and so we weren't able to red flag the ones that didn't pay us the full amount, and now we're gonna be able to. Any projection as to how much more we're gonna be able to bring in?
No projection, but I could just tell you in the sense of sufficiency of the staff, and it'll take them less hours because those red flags, they have to find this populates for them, and then they can do the calling. So we just need to get that cash in faster as well. So, but no, I don't have actual numbers now. I can ask them if they can track it for us through this next year.
It'd be good to know how beneficial it was for us, right?
Once this is implemented, will it retroactively reconcile what is there, just in case anything is missed?
No, it won't. Staff will just have to manually go through those. And they'll be able to tell us when they're looking at the agreements and what's in the system. If something was wrong, then obviously we know, okay, we really need to look at those payers that paid us because maybe something was put in wrong. So it'll kind of pinpoint a little bit for us.
So what happens is when the payment goes in, there's an allowed amount by the insurance versus what they pay. So that allowed amount will flag, as soon as this program starts, like if they pay $74.70, on the allowed amount for that certain code, if you look back, you'll say, hey, they can pay $74.70. So you'll see it right away.
Do you have any more questions or a motion?
So move to approve as presented.
I'll second.
We have a motion by Medart and a second by Garcia. All in favor say aye.
Aye.
Any opposed? Any abstentions? Motion carries unanimously. On to item G, authorize renewal of agreements with medical executive committee chairpersons.
So these are for the chief of staff and the chairs of each committee from each department. They go up for election every 2 years, so they went up in December. I believe the elections were in Dr. Indahar's report. So these agreements are just redone every 2 years unless there's changes between year 1 and year 2. No changes were made to the compensation, it stayed the same. And I did research what other facilities did and we were within. Right.
Do you have any questions from the board?
I have something to say. So, I'd say that both hospitals, also for regional and PMH, are in dire straits right now. And I believe that we need to keep as much money as we can for benefits, salary increases, things like that. And I also believe that the leadership of any organization needs to sometimes make sacrifices for the good of the organization. And being that month after month, there's a certain amount of money that's paid out to these individuals, these doctors. I would personally believe that because they're in it to win it, and we had testimony from a couple of doctors last time, that they want us to succeed. I think the financials are going to be what is going to lead us to succeed. We talked about taxes, implementing the tax. We talked about what it takes to run an organization. We've talked about how much equipment costs to run this organization. And in the paper, we have the IAD bill that's coming up here in November. The rate is going to increase. And I know we're going to pay a lot of money, a lot more money at this hospital because of the rate increase. Personally, I think that the leadership should sacrifice, at least for a year, and do this as just a collateral duty. And it really takes a leader to do something like that. So I would love and I would pray that the directors that are getting paid this money would give it up for a year and put it back in the pot so that if we do need to hire somebody else, we can do that or get benefits to the frontline people. Those are my thoughts.
Do you have any other questions or comments?
How many members are on the committee?
9 chairs in each committee, and then they all have a meeting every quarter with so if it's general surgery, all the surgery team will be there, if it's OB team will be there, and then they report up to my executive.
So do all hospitals have these chairs, or is it like, for example, and I'm asking out of ignorance, some chiefs of staff, medical chiefs of staff, do they do some of these duties where, you know, maybe if they already get paid a certain amount of money, they can do some of the other duties that some of these directors do to consolidate the monies and have us save some money? Is that
In a
something
smaller
that's
hospital,
doable?
they would.
Huh?
In a smaller hospital, you'll see something similar to that, but in the larger ones, it doesn't really happen.
So if we didn't provide this funding to these directors, would they just like not do it? Or would somebody step up and do it and be a director even though they're not getting paid any money?
It's a good question. I imagine some would and some wouldn't, but
Okay.
I wouldn't be able to answer. for you.
Because in some organizations, not just medical, people are directors because they put it on the resume. I'm not saying that's the case here, but it looks good on the resume,
Yeah.
but in some places, they get paid, right? I think that the benefit to be a director is huge because it gives you a voice to your individual unit. But again, I fall back on, I think, just for a year because we are in the middle of uncertainty with regard to our financials. I would hope and pray that our doctors would keep doing this without getting a stipend every month. And then my other question is, in looking at these, I didn't see anything about on-call. Is there on-call for these functions? Or are the
Providers themselves are usually on call based off of where they serve. As far as these are concerned, and those are usually part of their regular contracts. As far as these are concerned, it's not, this is not an on-call.
Not gonna be part of that, okay. So that's a regular function for their regular duties.
Yep.
And where is that policy with regard to the on-call? Where is that policy? With, like, how much do we pay them? Is there like a certain amount of hours they have to respond to, like, is there a distance, they can't leave a certain distance to respond to an on-call?
Yes, most of them have the provision in it that they have to be, if they're for emergency situations, then they're on call, they have to be within 30 minutes.
Within 30 minutes?
Yes.
Do they get paid per call, or do they get paid like for the month? And then when you're on
They
call?
usually get paid like so much for the call day. So if it's like, if I'm on tonight, for example, if I was on a provider and I'm on call tonight, then I would get X amount for whatever that is for tonight. And so by each day, if they took 10 days of call, then they would get that times 10.
Okay, and then when you're on call and if you do get called, is there a log that you have to keep to show that you responded in order to get paid? Or you just get paid whether you respond to something or not?
That's correct, you get paid whether you respond to something or not.
Where's that log? Do we have a, I'm sorry, do we have a log?
They have, yeah, they have a log on that that we have that will show who was on call for what, you know, with OB or whatever the case might be, who's on call on that day, and because they all work it out themselves, so each of those different disciplines, the providers that are there will say they have like, I have 5 days I'm doing as part of my contract, or whatever it is, I'm taking, you know, I can do these 5 days, and everybody kind of fills in those gaps, and then they'll fill in extra if there's days that aren't covered, and we have a log of that. We have like who covered what, and so our med staff team actually keeps track of all of that, and then puts and fills out the information for Carly for her days. Here's how much she gets paid for the month of January, based off of her call time.
So the log, if it has you on call today and you can't make it and you call me and I respond, will that log reflect that I'm the one that actually showed up?
Yes. Yep. Yeah, and so, I mean, I just had that happen here the other day where one of the providers actually picked up a couple of days because somebody else couldn't, and so we had to redo theirs to account for those 2 extra days.
Well, how much do we pay the doctors for being on call?
It's different for each discipline, and it's based off of the data that we have for, you know, we put it out there to find out what is the normal rate for call for X provider, for Y provider, for Z provider, and then that's what we negotiate with them.
Do you use that log to determine what type, let's say, say you get a lot of calls from maternity, obviously you need OB/GYNs and, you know, the baby pediatrics and all that stuff. Do you use that log to determine the need of certain staff for those types of calls, emergency calls, I'm assuming?
I guess.
So if you have, scratch that, I was thinking about something. Where is that log? Where is that log located?
Med exec. So our med staff team that we have here, they do all the credentialing and they do all the stuff. They work with Dr. Nahar and the rest of the team. They are the ones, they're the keeper of that as far as who's on call when. They have a full-on like calendar, and so it does it by discipline, and it shows the first and second was this doctor, third, fourth is this doctor, fifth might be this one, sixth, seventh is this one. And then so they have that full log of who that is, who's on call, and if there were changes made.
And the physician will call into medical staff to let them know that they changed the day with the physician, so they can make sure that it's updated. And it's on the intranet, under the provider's, link, and then you can click in there and see the schedule who's on call for them.
And as far as what we pay them, who determines what we pay them? I mean, is there a metric that's used?
Yeah, so we use like MGMA data and so forth that tells us in this area or, you know, around our area, this is the typical pay for a provider and typical pay per call. And we'll use other stuff too. We actually, on a lot of this, we actually put a lot of it out, like Carly had said for some of these others, to make sure that we were in the right spot. Because of course, you know, anytime we do any of these, that always is going to come to question. And people are going to say, hey, I think I should get paid more per call. And so we're always looking at the data to make sure we're in the right spot for how much we pay per call.
And that has been an ongoing conversation with physicians in the last 6 months, as they're requesting an increase. We did put that out there to be looked at. because there's a discrepancy between the call for both facilities, so we can see what the ranges they're requesting.
All right, I didn't mean to get off topic. I'm going back to what I said originally about the doctors just bypassing their pay for a year.
And I think they, I think they've actually done that
it a lot,
recently.
yeah.
20
Years ago when we had,
When we were
really
there.
were struggling, they did.
I think we're struggling now again, so I would hope they do it again.
I'm sorry, I was with her on, IVHD hospital struggling.
If I could interject here, I guess being married to a teacher, I understand that they're extremely busy. I understand that doctors are extremely busy, and when they take on these extra duty assignments, that causes them to be a little more busy. So I am perfectly fine, and in fact, I will make the motion that we go ahead and approve the recommendations here as presented. I do believe that a workman is worth his hire, and for those extra duties, it's valuable, and if we want the best, then we need to be willing to spend a little extra to get the best. That being said, I do somewhat agree that if there is anyone out there that wants to volunteer their time, we're always willing to accept that as well, but I don't think you should have to. And if we are, I notice it is budgeted, it's something that has been done, and I do believe that our department chairs, because you are putting in that extra time and energy, are valuable. So I will make the motion to go ahead and approve this agreement, or authorize the renewal of the agreement for the medical executive committee chairperson contract values approximately $60,000. Well, this says 76,000, so maybe I'm on the wrong line, but yeah, that's my motion.
No, second. So is it the 60,000 or 76? 76?
76.
Okay. For 2 years. For 2 years?
Yeah.
Okay. On our agenda, it says 60.
Yeah. Thank you for clarifying.
Do you have a second?
So wait, just 1 second, that's 76,000 annually, and the contract term is 2 years, so it's double, right?
No, that's a total, 2 years. 76.
Okay, so it says contracts value 76,000
I
annually.
added that it's 2, I did the numbers. So they get, it's $694 a quarter.
It's a quarter,
It's
not a
not,
month.
it's not a ton of money. so.
Yeah, thanks for the clarification on
Yeah.
that. Is there a second of it?
So really quickly, my recommendation is gonna be if, for the motion to be, in lieu of Director Goodsell's motion as presented, which mirrored the language of the agenda, it appears like we should, potentially, the board should consider the authorizing the Chief of Staff Consulting Services Agreement as presented in the agenda packet. Since there seems to be an inconsistency between the agreement in the packet and the, 2-year agreement versus a 1-year agreement. Sounds like this is a 2-year agreement, and it's agendized as a 1-year agreement, and then it's 76 over 2 years, as opposed to 60K for a contract term of 1 year. So I think, especially given the items in the agenda packet, we've achieved substantial compliance with the Brown Act in terms of the way it's agendized, but I would recommend that the motion be, if you'd like to make it, Director Goodsell, to approve the Chief of Staff Consulting Services Agreement as presented in the agenda packet.
Yes, I will make that my motion to approve the Medical Executive Committee Chairperson's contract as presented in the packet, which is a 2-year term for approximately $76,000 for that 2-year term.
I'll second.
I just wanted to know that in the agreement for Dr. Indenhar's agreement, it says he's the chef of staff. Chief of Staff.
What's for dinner, Doc?
Yes.
And we'll change it to IVHD instead of pioneers.
Thank you.
So I have a motion by Good South and a second by Garcia. All in favor, say aye.
Aye.
Any opposed?
No.
Abstention?
I'm going to abstain, Madam Chairman.
Thank you. Motion carries 5-1 with 1 abstention. Now we'll move to item H, authorized medical directorship for cardiopulmonary services with Sohi Tariq, MD.
So this is an agreement with Dr. Shea for directorship services for the cardiopulmonary department.
Did you go to?
Was it? No, it was. Do you have any other questions?
Any questions? Seeing none, I'll entertain a motion.
Okay, my microphone is the one making the feedback or something?
No, but
Okay,
it's
there we
too
go.
loud.
I move that we go ahead and approve the medical directorship agreement as presented here in the packet.
Okay. Do I have a second?
Second.
I have a motion by Goodsell and a second by Valdez. All in favor, say aye.
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 Any opposed?
Me.
Any abstentions?
I'm abstaining.
Motion carries 5-1 with 1 abstention.
Madam Chair, I'm so sorry. Can I revisit item G really quickly? I just want to be clear for the minutes, and I want to ask the board for clarity. With respect to item 5G, is the board aware that there are multiple agreements? This is agreements plural. So it's not just the chief of staff.
Agreement.
Okay, good. I just want to make sure that the motion was clear that it was for agreements plural for all of the agreements attached to the agenda packet as item 5G. Okay, good.
I thought I was clear.
So now move on to item I, authorized medical directorship with Dr. Mohammed Mahazmi.
This agreement is a directorship services. This agreement is for directorship services for antimicrobial stewardship and infection control programs with Dr. Algerson. He also helps with the PMT.
His specialty is infectious disease.
Yes. Any questions?
Do you have any questions?
I do have a question, and it's kind of related to all the contracts, I guess. I know we're talking about this one, but it talks about a little bit about how the director is going to make sure that there's compliance and things like that, right? Within each department. So who oversees? I mean, like, does OIG come down and make sure that we're complying with what we're supposed to be doing? When's the last time we had an OIG audit come down? Do you know?
I don't recall, for as long as I've been here, us having one.
I don't think you would want to.
Yeah, they usually come in if, there's an issue or, they get alerted about something big. We don't want them here. As far as compliance, they're providing services to us. So for example, Dr. Al-Jazeen, he helps with PNC. He's the chair of that committee, which has to do with pharmaceuticals. But he also, an antimicrobial, so he gives guidance, provides feedback as far as what guidelines we're going to use, what medications we can use. And then he's also available for our infection control practitioner. So when we have questions regarding cohorting patients, what kind of care to provide for something unusual that's infectious related, he'll provide guidance for us. We can actually call him and say, hey, you know, we have this type of patient here with this going on. How do you think we should cohort or isolate? What kind of treatment do you think we should provide? During COVID times when we were working on our procedures, our protocols for COVID, he was very much involved with that as far as providing guidance as far as what isolation precautions we should take or what kind of treatment we should be providing, that sort of stuff. So I think that the services that they provide as far as their directorship is valuable for the clinical staff, the directors as well. They always are available to us if we have questions. You know, we're able to discuss those things. If we ourselves have concerns with them, you know, like maybe they weren't being responsive, which that hasn't happened, but then I would take it up with the CEO, Chris, and say, hey, you know, I'm having this issue, or can you help? And then usually he would get involved in that. So that's kind of how we use the directorship roles within our organization.
So going back to compliance, who is our compliance officer? Do we have a compliance officer?
Yes, Araceli.
So I disagree with not ever having an OIG type entity look at an organization. I know that those types of inspections scare a lot of people, but guess what? They also keep you honest. And sometimes you find out that the way that we've been doing business is maybe not the right way we've been doing business, and I actually agree that an OIG inspection is due every once in a while to make sure that we are compliant with things.
So I would also, just so that you're aware, we do have that comes in from a state level. Like, we are DMB accredited, and so DMB, whether it's DMB or it's JACO, or the Joint Commission, they actually come in and do a full audit of all this thing, policy and procedure-wise, which is the stuff that these guys help us with. And then they make sure that we're following those policy and procedures, and then we get essentially like a form of a tag that we're either in compliance, substantial compliance, or not in substantial compliance. And when they leave, they give us that report, and then we have to fix those items. And if it's egregious enough, they would come back and review that. Otherwise, they would give us what we call like a desk review, where we would send in the information saying, these are the things that we've fixed. Here's the documentation that supports, you know, here's how we fixed it. And then they would say, okay, we accept that or not, and then they would be okay and clear us on those findings, and then we would gear up for the next time that they come in. And that goes through, and that touches every discipline within the hospital for all of those policy and procedures and all the things that we do to ensure that we're following all of those policy and procedures.
So I'm glad you brought up DMV. About a year ago, I had brought up the issue that dorm replacement center was advertised on the internet that it was certified by DMV for like 2009, 2010, and then it skipped to like 2012 or something like that. So one of the questions I had is, why is 2012 the last year we were certified? And I didn't get an answer. And then it turned out to be that we actually, the dorm replacement center wasn't certified by DMV at all. And then the information still stayed on the website that it was a certified, I can't remember when they used the term, Center of Excellence. Sorry. So it took somebody that has no knowledge of medical to just have make a small inquiry, and then we come to find out that there's been false advertisement from this center, and it was never certified. So my concern was that you've got people in the community thinking that it was certified when it really wasn't. And if it wasn't, maybe they would have had other options to go somewhere else. But to me, that was false advertising. So going back to the issue of, I think it's a good idea every once in a while to have an outside organization come and look at your organization to let you know, okay, you guys are good to go or whatever. Right?
Just to clarify, we were actually certified for a few years. The problem is that once we no longer pursued the certification, we were not diligent in going back into the to the webpage and removing that. But we were certified for a few years.
Yeah, so the answer to that point was that, since we already met the certification standards, it wasn't like, we needed it anymore, or to apply for whatever they do, the inspection or the certification process. But it still said DMV, although it wasn't, right? But you understand my point is, if I need to get a knee replacement, I'm like, they're certified, I'm gonna go get it done there, when it really wasn't. Anyway, that's it.
When is the next inspection for certification or accreditation, rather?
For DMV or general?
Yes.
So we usually expect them in May. There's a 30-day window, plus or minus, depending on when our last one was. And if I remember correctly, last year it was in May. So it'll be coming out soon. And we also have other ways, of ensuring that we are keeping compliance. And then we're very transparent when we do have an issue where we feel like we did something that we needed to report. Like we will self-report to CDPH or to whoever we need to report if there's any issues that we feel need to be reported. We're very transparent about that.
I love hearing that. That's how you learn, right?
Yeah.
To learn. Yeah.
And all of the ambulatory centers around, are they all under the same accreditation, or are they like AAA because they're not a hospital, or it's all under one blanket?
So we have DNB for the organization, and then
We also have a compliance team for the row house.
and then now with SNF, they have their own listing that comes in. And with DNB, they actually come in annually. Every 3 years is the big one, because you can say, but then on an annual basis, they come and do a more condensed look, and they look at it.
Just one last thing, I'm sorry. With the changing of the guard, if you will, as far as the board is concerned, will that trigger anything with the accrediting agency because of 918?
Usually, we have a profile for the organization that I keep up, and the profile is, I call our business information, our tax ID number, that kind of stuff, and then it wants to know how many employees we have and for what services we provide, and then based off of that, they know how many days they're going to be here and how many surveyors they have to send. So when I get the notification that it's time for me to let them know of what's going on, I will update that, and then possibly it might change to where we need more surveyors to be here for more days than usual, or it might not change at all because it's still the same services that we're providing, and we still have the same number of staff, and et cetera. So it just depends. I haven't done any of that because probably not the right time just yet, but I am aware that once we get to that point, I'll have to do that. I'm probably with CDPH too.
Thank you.
Do you have any other questions or comments, or we have a motion?
I move we accept the agreement with, and I'm going to apologize in advance, I have no clue on how to pronounce these names, but Dr. Mohammed M. Al-Jassim as the medical directorship for the, I'm guessing infectious diseases, but antimicrobial stewardship and infection control program.
Do you have a second?
Second.
I have a motion by Goodsell and a second by Metter. All in favor, say aye.
Aye.
Any opposed?
Me.
Any abstentions? Berger. Motion carries 5-1 with 1 abstention by Berger. I believe that is it for our open session.
Yeah, can I say something real quick? So I think there's a miscommunication because the finance wasn't on the agenda for you guys to approve, but you do have the financials in the packet. So I will go over that in detail at the next board meeting, but
It's on the agenda, it's just not numbered. So it's right above 5, but I think probably the chair
Oh, okay.
I just got it above
Okay,
five.
so then I talk about it or no? Wait till next one?
Wait, I don't want to catch you off guard if you're not ready.
I mean, I'll do a little, how about this? We can go over detail next time, or I can do one-on-one details with you guys, because I know a lot of this would be new for you. But I will just kind of hit the numbers that people really probably want to hear here. So obviously December, we had a higher census in December, which is normal for us. You know, we have a low in the summer, and during the winters it goes up. So we had an average daily census of 56. So I'm looking at the back of your, let's see, it says statement revenue expense. I don't know what page it's on, but it's towards the back of your guys' packet. So the third column over will be the month of December. So this will have last month, November, last year's December, something we added, and then obviously actual December. So a lot of what we talk about is our average daily census, which was 56. That just means all of the patients that are in-house, in your ICU, your med-surg, your OB, pediatrics, NICU, those are those in-house patients. Obviously, inpatient revenue collections are a lot better than outpatient revenue collections. So we did have an increase in our revenues, and actually our revenues were the highest that it's been, I believe, ever since I've been here in the 12 years, and thankfully to Cerner and all that, charge capture, that some stuff that we were missing out prior. We did have a pickup from prior years on some supplemental payments that it will be a one-time thing that we have, so that's down in our revenues reduction. Some things in the salary, the expenses to let you guys know. So our benefits did go up. You'll see that a lot. It's a kind of a roller coaster. We're basically self-funded, so we pay as the invoices come in. You'll see that during the winter, obviously more people are getting sick, so a lot of times our benefits are higher than they are. You also have a 12-month trend here you guys can review, and you can kind of see how that is on here. The same with supplies. Supplies are up in December, so we do expense out our supplies every month, but we also do have an outside vendor come in twice a year to count our inventory, just in case there's anything that is missed, and we have expense that out. So we can see here we had a big expense in December. We realized there's some things in Cerner that still need to be corrected and expensed out. So that total expense isn't for the month of December. It would be for July through December. It just hits when that outside vendor comes in to, basically audit our inventory in a sense. So for the month of December, our profit was $932,000 for the month. So fiscal year to date through 6 months, we have a profit of $2.5 million. So that will be a quick one. You guys will see you'll have this P&L. You will have the 12-month trend that you can look at. We do have some key operating statistics in here as well. And then a little narrative, which I am actually hoping to change to make it a little bit different for you guys and make it just a little bit easier to read. So I'll bring something different. I don't have the balance sheet in there. I will give you guys November's balance sheet. There was a glitch in the interface from Cerner, so I didn't want to bring you guys something with wrong numbers. But in November, we did have about $37 million, and in December, we had $34 million. Like I said, we had a dip in cash. And then we did receive IGT payments in January. So the next few months, you guys will see again that roller coaster of cash in, cash out, because like in November, we had to pay IGT, but in December we got $6.6 million back. Sorry, IGT is intergovernmental transfer, and I'll also send you guys. There's different supplemental payments that we get paid. Mostly they're for Medi-Cal managed care patients because we do not get paid very well on those patients, and so we get these supplemental programs. In a sense, if we sign these agreements, some of them have agreements, some of them are just we get the money. But it's say send $1 million up to the government, DHCS, then I'll get $2 million back. So essentially, I get double my money. So you always want to send those IGTs up. We have certain quality programs for that. There's a bunch of different ones that I will give you guys more detail on those different programs. Starting this calendar year, we will lose out on 2 of them because one of the newer programs is potentially increasing substantially, but that just means we're going to lose out on 2 of them because we have an upper payment limit where we can't receive more, like on our DISH payments. It's a disproportionate share hospital. We can't receive more than X amount, or we have to pay back that payment. So that's where that stuff comes in. But like I said, I'll go in more detail throughout the next couple ones to kind of give you that. But what that happens is, say in March, I have to send up $3.1 million for 2 of those programs back. So it takes 2 to 3 months to get that money back, and I will get anywhere between $7 and $9 million back in May or June for those supplemental programs. And about 12 to $14 million right now is our revenue on those programs. And then that will potentially, what I've been told, will increase to over $30 million for this calendar year. But I don't count my chickens before the eggs hatch. So, like I said, if you guys have any questions, feel free to reach out to me. I can do a one-on-one to kind of go through these in details with you. The more you understand, the easier it is for me.
On the key indicators,
Yep.
is the skilled nursing facility on
It is not on here, but we can add it.
So anything you guys see like that you're like, okay, I would like to see that as part of that, let us know, we can add that to that, so it can be something that you guys want. And see if you want to change layouts on certain things too, just let us know, we can make adjustments.
And it's not on there, it is in the narrative, it talks about, it did go up a little bit, but our average census for that was 71.4 for December, so that part is in the narrative.
Yeah, I did see that in the narrative. And then, so, like on here, FTE for your, that's full-time equivalents, yes?
Yes, so
Okay.
2,080 hours, so 40 hours a week person.
Okay. And so, are these average, you know what I mean? So like full-time, you know, on ADP, it's like 8.95. So are you averaging it by like 40 hours a week? That way it doesn't come out to a full number.
No, that's a, FTE, it's a, basically a per day, per patient. Yeah. It's, actually shouldn't even.
And then, what's the difference between worked and paid?
So worked is anytime the employee is working, paid is their worked hours plus their PTO, sick time.
Okay. That's what I thought.
Yeah, in productivity, we always kind of look at the worked because we want to make sure everyone's just working their, either their per patient day or their hour per workload unit, because we have to flex a lot for the census in a lot of our departments, because we, obviously don't want to be short-staffed or overstaffed, we have ratios, and so that's why work's important, but obviously everyone has their paid.
I have a question for you.
Yeah.
So on the revenue deductions for the indigent care write-offs, I'm noticing that it's the same amount across the board except for June.
You're looking at the 12-month trend?
Yeah, right here. Yeah. Under the revenue deduction, it's the last entry.
It's because we get a flat amount throughout the year, and I don't know, I'll have to look back on why June was different, so, because it should be the same money, we get money from the county for that, every year, it's been the same amount since I've been here.
So
I would have to see why June is different.
I think at a previous meeting I had asked about that particular issue, and I believe the response I got was, I don't remember if it was you or not, or maybe you, Chris, that we paid like $1 million for unfunded, more than that, right? So where does that fall in here? Those amounts of money, like for example, undocumented immigrants, people that don't have benefits, things like that.
Oh, you're meaning like our charity write-ups or bad debts. So your charity write-ups will be, it says here charity write-offs, and then the front P&L. I mean, it's on your
Okay.
12-month trend as well, but there you can see the difference of month to month. So that's charity. Those are the ones, there's a state policy that we have to follow, and there's certain guidelines to actually apply for that or be eligible. So that will be your charity there. And then your bad debt is basically the patient's not paying. Yeah, and we do get a portion of that back on our cost report. So even though it says $1 million, say for 1 month, we would get back about 65% of that for the Medicare side of that. We get back a percentage, so.
Yeah, I would actually like all the clinics, you have the census, but I would like to know the revenues and the expenses on all the clinics, because they're all new to them, to the board, and so you need to present each clinic and the nursing home separate, so we can look at all the numbers individually and then go back to the summary. I don't know how you guys feel about that, but I think you want to know how all the clinics are working.
Yeah, I'd like to know like department wise, like
Yeah.
which departments make money. which
Yeah,
ones
just,
aren't.
we have the list here of the census, but we don't have like the expenses or the revenue or anything like that. So we just have the number of things that we did. But I think putting the expenses and the revenues next to it.
Do you just want clinics, or you want in the quarterly ones, or?
No, actually, I think the next time you present, you probably should have it, and then until they get it under their belts, and more or less. But I also think the nursing home should be in here as well, separate. That would be my request.
To break it down by facility and then just give like an EBITDA and then the actual
Yeah.
expenses and then how it breaks down.
Any other questions? Thank you all for all the staff. I know we are gonna overload you with a lot of questions, and you guys just got done doing a bunch of heavy lifting these past few months, so I really appreciate it.
It's November.
So with that, the board's gonna go into closed session.
Ready.
Okay,
Do we have any reportable actions out of closed session?
yes, Madam Chair, the minutes should reflect the board adjourned from closed session at 9:48 PM. There was no reportable action taken with respect to items 6A or 6B. With respect to item 6C, the board took the following reportable action. The board took action to dismiss the PMHD General Counsel. Basis for dismissal shall be set forth in a termination letter effective, with an effective termination date of February 3rd, 2025. The motion was made by Director Madart Jr., seconded by Director Proctor, and the vote was a 7-0 unanimous vote. That's the only reportable action taken.
That, I'll call the meeting